Thank you. Next slide, please, Sharon. Thank you, and thank you all for joining us. So I'm talking about cognitive impairment and cancer today. Cognitive impairment can come for lots of different reasons, and as I'm sure you're all well aware of, that within cancer there are so many other conditions which still affect these people, and cognitive impairment may not come from their cancer, but then it's a double whammy that they and their families have to deal with. Next slide, please. Thank you. So to start off with, I think it's helpful to understand what do we really mean by cognitive impairment. So I think the general understanding is it's when the person is unable to fill their functions as they normally would. So it can be their memory, it can be simple tasks that they would have carried out, it's their thought process that doesn't run as it previously would. So it can be from the simplest daily tasks like brushing your teeth. You've got your toothbrush, you've got toothpaste, but you cannot process the thought where the toothpaste needs to go onto the brush and then it needs to go to your mouth. It's these things which have been wired in our brains for so long since being a baby that suddenly aren't happening. And you can imagine what sort of thoughts and feelings that must provoke in somebody. My speciality is brain tumours. So for a lot of our patients, before their diagnosis, they've often had a really frightening time where they're thinking something's changing. It's quite disorientating and they don't really understand why. Some of these things are quite subtle, so you wouldn't necessarily notice that some of these impairments are there in somebody. There are things that people do to mask these deficits. They don't necessarily understand why they have them or how they're impacting them, but they know something's not quite right. So we had a patient who used to ask what I thought was an absolutely brilliant question to mask their impairment. And they would say to people, what would you do if you were me? And you think that's such a great question, because that doesn't suggest to you that that person doesn't know what's going on. It doesn't suggest that they have any confusion at all or they're not following. It seems a really reasonable question, and you can use it in most instances. What would you do? What would you do if you were me? And it may be that that distracts even the conversation, because a person may not be all that keen to say what they would do if it was them, because we're not in their shoes. But actually it was something they'd used in their daily life at work. So it was a stock phrase that they had, which they knew really well, and they could easily just bring out because they'd always used it in their career. So it's really, really important that we're aware of cognitive impairment, how it might impact, how do we look for it, what could it look like? Could look like lots of different things. Physiologically, within our brains, the hippocampus is responsible for a lot of our memories. So if this is damaged, then it can often cause cognitive changes to do with our short-term memory, perhaps not our long-term memory. So it's selective in how it causes that damage. But you could have a lot of reasons why your hippocampus could be damaged. It could be a tumour. It doesn't have to be a primary brain tumour. It could be a metastases. It could be a bleed. It could be lots of different reasons. So it's important to work through why is that memory damaged. And Cancer Research UK have a statistic which I think is quite shocking. And it's 75% of people diagnosed with cancer experience some form of cognitive impairment. And that's why it's amazing that so many people are joining us today, because it really does matter. And it matters that we're aware of it, that we're ready to look for it and put in strategies to support it. Next slide, please. Thank you. So although I work all the time in brain, I love refreshing myself on what does what and where. And this is a slide that the Brain Tumour Charity have produced. And I think it's really helpful when you're working with people, both patients and their loved ones, to understand which bit of the brain does what and why are they behaving like they are. Because I think if you can reach a mutual understanding, even if the patient doesn't understand it to retain, that carer can say, okay, well, I understand their behaviour, I get why they're doing this, and they can try to make it less personal. although of course it feels very much that way for them. So if we looked at this picture of the brain, you think actually most areas, if they had damage in, would change our cognition. Our frontal lobe, for example, has all of our executive functions in. So it's our planning, it's our decision making. Do we make wise decisions? Are we making good choices? Well, if you've got damage in there, your ability to make a good choice may well be impaired. And so how do you then make that choice? The speed, the processing, the thinking, the frontal lobe can really affect our ability to initiate activity. So when we go to initiate activity, we have to really get up and go. It's not just seeing that something's around you. And if you think about a scenario where you've got your patient and you've got their loved one, their home's busy, they might have young children, there's mess everywhere, their loved one's running around after potentially a day at work as well, exhausted with all these tasks obviously in front of them. The person who's got the frontal lobe area damaged will look around it, they'll see it, but they won't be processing, what should I do about it? And often in that scenario, perhaps we're not as able to communicate as kindly as we would if we really understood why they weren't getting up. So somebody might quite passively aggressively say, oh, don't worry, I'll do it all, as they're running around feeling quite stressed. But what the patient's hearing is, okay, great, yeah, you're going to do it all, no worries, you carry on. Because they're not thinking, oh gosh, that must be really awful for you. And they've not got that ability to get up and do it themselves. They need really clear direction because that part is damaged. So they need to be told, I need you to please get up and help me with this. And what I need you to do is this. Really clear direction. So showing somebody this picture of the brain and saying, this is what's going to be affected by this tumour, this bleed from other cancer treatments, for example, whatever the reason the damage is there, by explaining it and visually explaining it to the patient, you can really try to help them get at least a better understanding, even if it's only in the moment for that patient. When we look at things like the temporal area being impacted, it's a lot of recognition. And so cognitive impairment can be inability to recognise people you've known for ages. Faces don't make sense. Who are they? I know them, but I can't think who they are, which again must be really frightening for somebody and very hurtful for family members. So I think it's really important just to take a few moments when somebody is diagnosed with cognitive changes or a tumour or something that's going on in the brain, to sit down with them and say, right, this is where the damage is. This is what it could impact. This is what to look out for. Some of the physical changes are obviously much easier to deal with because they're obvious, you can see them. So these subtle ones are something that we need to look into just with a bit more depth. Next slide, please. Thank you. So why do people get cognitive impairment with cancer? So tumour location we've just looked at. As we can see, most areas of the brain will impact on our cognitive function because it's our control centre, it's our mastermind, it's where our personality is, our emotions. Drugs, all of our patients will be on a number of drugs. Some not loads, but others could have, a reamful of things when you throw in the supplements as well. When I think about our brain tumour patients, anti-epileptic drugs are used for the vast majority because of the risk of seizures. The older ones really impact on thinking and memory and our ability to concentrate. And although the newer drugs are much better, you still will find that first few weeks of somebody taking those drugs impacts on their fatigue hugely, and they feel really very foggy. So it's really important that we also support them with that education because we need them to stay with those drugs to try to prevent or decrease their chance of having seizures. It's also trying to help them. Why do they feel like they do? And is it going to get better? If it's really impactful, we risk them not taking drugs, which actually may be really important to them. So it's working out, how do we support those cognitive changes that have come from those drugs? A lot of people talk about chemo brain. So anybody who's having systemic treatment, although we've got our blood-brain barrier to protect our brain, a lot of people will find this brain fog, this chemo brain. So various treatments can impact our cognition as well. If you look at one of the major causes, fatigue. Fatigue comes with cancer, doesn't it? You know, any of the treatments that we give, even just our appointments, coming for scans, coming to see us in the clinic, really stressful. Every appointment, really very high energy, because they need to concentrate and hear, decision make, understand what you're being told, which when your brain isn't working kindly with you is a much, much harder process than it is otherwise. And it's one that is hard to see as well. Later effects of treatment. So sometimes people have had whole brain radiotherapy and gone on to live with their disease, and they will then have a premature aging of the brain. So they will then have cognitive changes due to the treatment that they had previously. Childhood cancer treatments are one that we see with secondary malignancies 30 years later. And often those people, because of their brain being treated when it was in such an early stage of development, have never cognitively been able to function as they would have done otherwise. The menopause is huge for cognitive change. It causes anxiety, causes depression. Again, the brain fog that people talk about with the hormone changes. A lot of people with cancer will have been thrown into premature menopause, or medical menopause. So for the ladies with breast cancer, they are often on quite grueling regimes, and then their body's been thrown into a medical menopause and they don't know where they are because they're anxious, they're depressed, and everyone thinks, well, fair enough, you've got cancer, but then their body's going through the menopause at the same time. So the cognitive impairment, we know, can be helped with hormone therapy, but not everybody with cancer can take that. There are a lot of other options which can help cognition with the menopause for cancer patients. So there's a few good resources that we could direct them to help look after their brains well during that time of their lives, give them back a bit of power as well. Stroke, so a bleed in the brain anywhere, can cause cognitive impairment. People with cancer are often more at risk of these bleeds because of treatments we give. For example, things like Avastin, bevacizumab, that can cause an increased risk of bleeding. And so it's looking at which area of the brain has been impacted by that as a consequence of their cancer treatment and diagnosis. Traumatic brain injuries. When I think about a lot of people with brain tumours and secondary brain tumours, the metastases are most commonly found in the back of the brain, so in the post fossa, and that's part of our balance area. So it's part of how we orientate ourselves and keep our balance. So you may well find that people have got cognitive impairment because they've had a traumatic brain injury because of this damage that's been caused by the tumour. There's also other reasons like Alzheimer's and dementia, which I know Dia is going to cover as we go on. Next slide, please. So what does it look like? It looks like people being forgetful, telephone messages, people calling and saying, I'll be over at this time, turning up at the door a couple of hours later, and the person that's standing opening the door thinks, oh, that's nice to see you, didn't know you were coming. And it's because they haven't retained that short-term information. So verbal information is often really difficult to retain. So it's so important to write things down. Inability to recognise faces, short-term memory, behaviours change. People might become quite aggressive. A lot of aggression comes through frustration. People being unable to manage at work. But because they've got a lot going on, it depends on your workplace as to how supportive they are. How obvious is it that you're not coping? How obvious is it that you haven't done what you were meant to do, or that what you have done is not to a good standard? In some jobs, that might go on for quite some time before it was picked up. In others, we've had people working in, risk jobs in financial institutions, and they're very on whether they can be at work or not. What's hard is when that's mixed with assumption. So not everybody with a brain tumour will have cognitive impairment. And the expectation that perhaps they might can be really difficult for people who actually are able to function in their work. One of the things that can be really helpful to signpost people to in that situation is towards a neuropsychology assessment, because that will really detail through how somebody's cognition is working. It's quite a hard assessment to follow if you've got cognitive impairment, because it's tiring and likely your cognitive performance will be worse because of the fatigue. But it's a really useful tool to have to say, this is where the changes are. There's lots of others, but for our patients, having a thorough neuropsychology assessment really helps them come together with their workplace and also their loved ones. It also helps say, this is where the damage is, or where your function isn't as we would expect it to be to someone of your level of education and career. So it's quite a good assessment for people to go through, and available in NHS. So it's not something people have to pay for, which is important. We will often see in consultations, and if you're community based, you might find this in people's homes, there's a lot of frustration and disbelief of what someone's saying to them. So the insight can be impaired. And so if you're a patient sitting there being told that you haven't done something, or you did something in a funny way, you won't remember. And then you're being told this in a situation like a clinic, which is where people often feel quite vulnerable, and they won't believe it. And they will then be quite angry with the person who's saying it. And that creates this huge divide in what's already quite a stressful situation. A lack of awareness of others and others' feelings. So because when you have cognitive impairment, you can't read people in the same way that you would have done otherwise. They're not going to pick up on the nuances of somebody looking sad. They might notice they're sad, but they'll think, oh, what are they crying for? Because they won't be feeling it necessarily themselves. Some changes in language and speech and the way someone communicates, being unable to retrieve that word that they want. Some people who are high functioning still can find a workaround, choose a different word. They know they didn't get the one they wanted, but other people wouldn't necessarily know. But for other people, the words that come out are not the right ones, and they end up getting quite muddled. That can be particularly the case in social situations. So you can notice people withdraw from group settings and from going to places they used to through embarrassment, because they're worried that they won't be able to get across what they wanted to. Next slide, please. Thank you. So what can we do? It feels quite negative, doesn't it? But actually there are strategies that we can use with people to really try to help things improve. So we can suggest things that they enjoy. So is it puzzles? Is it jigsaws, Sudoku, memory games? There's always something in there we can find that people enjoy. So following a knitting pattern, there's lots of crochet is now much more popular. Knitting feels like it's something that older patients would do, and it isn't necessarily, but crochet is now a very popular thing for all ages. And it's that following a sequence, watching what you have to do step by step and noticing if it's wrong. You're really working your brain. Repetitive activities are really good. Remembering where things are in the supermarket, but you have to build to those, because otherwise you'll be lost and frightened and not finding your loved one you went with. Writing things down, trying if you're in the community and in people's homes, suggesting that they have notes everywhere, something available to write down, a central place where if somebody's feeling confused at home, they can go to find these notes. If they've got visual impairments as well, voice notes are really helpful. We've got a lot of technology now, haven't we, to help us. Thinking about being inventive. If they're having trouble, a face is more helpful if it's writing down that's difficult. Do they just need some faces of people that call all the time, put them by the phone, put one up, did this person call? And then at least they know where to start calling to see if they can't remember the information they were given.
And Vicky, just giving you a 60-second warning.
Thank you. Understanding the nervous system and its responses is also really important to explain to people why things happen in a certain way and try to help them calm down. Next slide, please. So looking after your brain, so just general healthy things, they're all quite obvious, aren't they? Drink less, smoke less, take cigarettes away because people won't remember when they last had one. They're all quite obvious, but all really important. I have included on the next slide, I think it is neuroplasticity, just for information, just because I think it's so interesting. It's not something for now, but it's something if you're interested, you might want to look at about us rewiring our brain. And then finally, if we can skip over to the last slides, Dio is going to go into this in much greater detail. I think it's the one after that. That there's just a bit of a toolkit takeaway with a couple of links which might be helpful. But I'm going to hand over to Dio, who is an Admiral nurse from North Central London, and he has got a wealth of strategies to help with carers as well and looking at the bigger family picture.